Deaths from pneumonia plunged when antibiotics first came on the scene. But today, some of the germs that cause the lung infection are fighting back.
When you look at the whole population, you just see the bacteria getting more and more and more resistant.
Drug-resistant germs tend to linger within hospitals, threatening patients who are already seriously ill. But one resistant bug has been turning up in healthy people as well. It's a type of staph infection called methicillin-resistant Staph aureus, or MRSA.
Methicillin-resistant Staph aureus is a form of Staph aureus that has acquired resistance to our major classes of antibiotics, which include the penicillins and the penicillin-like drugs. We then become limited in terms of the number of available antibiotics that we have to treat this particular organism.
It would be rare for me to see a young, previously healthy person get seriously or critically ill with pneumonia, but we sure do see it with MRSA.
There are several drugs that can fight this rare form of pneumonia, but timing is critical.
The sooner patients get treated with the right antibiotic, the less their chance of dying from their pneumonia.
The problem is, lab tests can take up to 72 hours to identify drug-resistant bacteria, including MRSA. So the patient may initially be given an antibiotic that is not effective.
We need to get the right drug started soon, and waiting 24 to 72 hours is too late.
That's why many doctors advocate a strategy known as de-escalation.
If I have a patient who has a serious infection, a pneumonia, and it's not entirely clear what the pathogen is, I'm going to want to start out with an initial antibiotic regimen that's going to cover most of the likely pathogens.
As we get back our diagnostic, our culture data, we have the opportunity 2 or 3 days later to look at that information and to narrow and focus and reduce the number of drugs, the spectrum of drugs.
Proponents say this approach can save lives by avoiding delays in effective therapy. Even small delays can be dangerous if the infection has entered the bloodstream and spread beyond the lungs.
If we have evidence of other organ involvement, even hourly delays, a delay in 1 to 2 hours, may be associated with worse clinical outcomes.
The medical community hopes to prevent new forms of drug-resistant pneumonia by using existing antibiotics carefully.
We try to get by with the shortest course of antibiotics in terms of the number of days as we can from a clinical standpoint.
Another way to limit antibiotic use is to help people avoid pneumonia in the first place.
And pneumococcus is the most common cause of community-acquired pneumonia, and we have a very effective vaccine for that.
The flu vaccine can also help because influenza makes some patients more vulnerable to bacterial pneumonia. Unfortunately, there are no vaccines for the most dangerous forms of pneumonia, which is why a strong arsenal of antibiotics remains essential.